I am Dr. Varinder Singh. I am a Director Professor of Pediatrics at Lady Hardinge Medical College and associated Kalawati Saran Children's Hospital in Delhi. You see, child health in the world can be divided into two predominant spheres. One is in the developing world and other is in the developed world. While developing world continues to struggle with infectious diseases, early childhood mortality because of poor neonatal care, the developed world has a difficulty of dealing with highly premature children about whom we do not even conceive survival in countries like who are resource challenged, and then their continuing morbidity because they are born too early, or they are dealing with the lifestyle diseases like obesity or substance abuse or teenage pregnancies. So there is a complete divide onto the child health issues which you see across the world. When you look at India, we have a kind of a double whammy. We are a very heterogeneous society. While part of us are very resource challenged, we live in poverty and have excess issues to health. There you have the issues of infections being a major killer, whether it is a respiratory or gut infection, which you very commonly see as one of the major killers for children under 5. In addition to that, the other major contributor to under 5 mortality and morbidity in our country is unsafe child birth, which leads to difficulties of the neonatal deaths because of prematurity, because of birth asphyxia, because of infection, because of hypothermia, and therefore a large chunk of children in our country die early on because of these services, lack of these services, which I must say then in last decade have seen a tremendous improvement. We have had our infant mortality and neonatal mortality which has gone down significantly. We are closer to achieving the sustainable development goals, but yet it is a long way to go to reach where we aim to. The older children continue to struggle with infections, which is a reflection of poverty, which is a reflection also of overcrowding and lack of access. While this is true for those who are economically disadvantaged, we have a large middle class and upper middle class population in our country, and children in those situations have got all the lifestyle diseases you see in the developed world, and therefore nearly 10% of the elite students from the elite schools would have obesity, would have childhood hypertension, would have propensity towards diabetes mellitus. So we therefore seem to be having a double epidemic of both the situations which are seen in resource constrained countries, also those which are seen in the developed countries. You see, we at Lady Hardinge Medical College we are more than a century old college who have a distinction of training girls only as undergraduates, and then we have both the gender as postgraduates. It's a long heritage, and a very high quality training is provided. Speaking for my hospital, which is Kalawati Saran Children's Hospital Department of Pediatrics, it's more than 50 years old, and here we started as subspecialties of that time. When there was a lot of polio in our country, and it started with the Russian support, and we had one of the largest physical medical rehabilitation department in 60s. Now we have a department which is comprehensive, provides free public care for all childhood illnesses, and we also have a lot of good subspecialties. We have one of the best working ICUs here. We have a neonatal division department which deals with children who are born early. We have many subspecialties: hemato-oncology, gastroenterology, endocrinology, pediatric pulmonology, hepatology. So we have neurology is a very important segment which we deal with. So we have practically all the subspecialty care which is available, and have a niche place in providing specialized care to the children. Challenges are that, you see, in India there is no hierarchical use of facilities. So when I am sitting in this tertiary hospital in my OPD, I could be seeing a upper respiratory tract infection which can be easily dealt at maybe a dispensary or a small place. So there is no referral system, and there is no limit on patients which I have to see. So that somewhere congests the schedule of every doctor. as a result of which the time you would like to devote to a more complex case, there is a price on that time, because there is a larger burden of patients with simpler diseases which can walk in. So despite having a tertiary care model of delivery, we continue to provide care for all levels, because that's our mandate, being a public health institute. So that becomes sometimes very challenging. We also have more than 100% occupancy of our beds. Therefore, there is always a stress on the resources, despite the best effort made by the administration and the doctors working here. You would be surprised to know that most of our doctors, they work far longer than the expected time. We have never stuck to a 8-hour schedule. Our schedules are like 12 hours or maybe longer than that. So that's another challenge, because somewhere it leads to a fatigue. And with the current time, where the kind of confidence the community has in the profession is going down, the communication becomes harder because of pressure on time, and that further affects the relationship with the community. While there is a focused effort by our department to ensure that communication happens, the government has provided us facilities for online reservation. We use systems which can facilitate waiting, which can decrease waiting and facilitate easy access to care for our patients, but yet the numbers are too huge. So challenges remain. Way forward, I would say that perhaps country needs many more centers like ours, because why should, more than 50% of patients which come to us do not belong to this state. They come from neighboring or distant states, sometimes different countries also. But then those are selective referrals. But this constant, the flow of patients which is from the neighboring states, for lack of facilities which are of the same level or similar reputation there, creates a pressure, unnecessary pressure, and also it is a challenge for the families. It's not easy to travel 200 miles and stay there for the treatment of your child. Therefore, having more centers which can provide similar care in more than one in every state is what we need, so that this flow of patients is only for some specialized care which may not be replicable everywhere, which is fine, where you would have center of excellence for some diseases at some places. But this routine flow of anything which gets a little complicated to one hospital or two hospitals or three hospitals creates totally overcrowding. It is not the right kind of access which one would expect. From a public health viewpoint, I would say the government is taking the right steps. We are at this step of time trying to strengthen all the district hospitals. The current budget talked of a lot of strengthening or converting the district hospitals to medical colleges. But then, health being a state subject, these policies take longer to actually actualize, because of the gap between what the center would decide and what the states would do. The priorities sometimes differ, or sometimes the allocation of resource or funds are not as much. The controls or priorities may be different. But this is the need of R, that the district hospitals, there has to be a decentralized care through some nodal facilities, be that a district hospital. For a secondary level, it should be a community health care, so that patients and families are not disrupted just because they are sick. I am not suggesting a model that everything should be available at the doorstep of the patient, but the healthcare access should start at the doorstep. It should gradually increase with the complexity, and those facilities for the complex diseases should be available in a reasonable distance and not be localized to few centers in the country, because that is not helping either the center or the patient.